your single clinical trial is not going to be the thing that determines safety, right? It's a great way to examine our primary endpoint, our efficacy, effectiveness. A single clinical trial is not going to demonstrate safety as much as we wish it would. Why is it not optimal? Well, when you think about what you guys have all been working on, right, we have this primary efficacy question. That primary objective of your study is driving the sample size, it's driving the type of design you have, right? That efficacy hypothesis is what we've been focused on. Our safety hypotheses, though, can't necessarily be always pre-specified, because usually you go into a clinical trial anticipating rare events. You don't expect to have a ton of safety events, right? We don't want to have those harmful effects. Most trials are not designed to detect differences in safety outcomes. Now, sometimes your efficacy outcome is a safety outcome, right? It's death, right? Or if it's severe ICH or something. But we define that as our efficacy outcome in those studies. We have a bunch of safety outcomes that we also collect, but we never power our studies for those safety outcomes. And so it's really, in that setting, it's really hard to prove a treatment is safe, right? We all know that if you do a hypothesis test on your, let's say, rate of migraines, and you fail to detect a difference, that doesn't mean that you prove that it's safe, right? We know that we never prove that the null hypothesis is true. So what do we do in clinical trials? We focus on trying to collect information to identify harms, right? Not to prove that something is safe. So at the end of the day, when you're writing up your papers or when you're reading the literature, you usually see this term or this sentence saying, no safety concerns were identified in this study, okay? We have to rely on multiple resources to understand adverse reactions. So not just your single trial, you're gonna go see what was happened in this population in other studies, right? We know that we're not the only ones studying a certain patient population or a certain intervention. So we rely on epi studies, we rely on other trials being conducted. But the main thing with your study is that we really have to do due diligence in collecting this safety information, especially when we're talking about collecting information on rare events. Safety is something that's going to go through the whole clinical trial cycle, right? When we start from your phase 1 dosing studies, we've had some conversations yesterday in small groups about monitoring for safety in that setting, but we're doing this all the way through post-marketing studies as well, right? So just keep that in mind. Adverse event reporting, the typical definition, right, the standard GCP definition of an adverse event is any unfavorable medical occurrence in a participant that's not previously identified, which does not necessarily have to have a causal relationship. A lot of times I talk to investigators and they think, why do I have to report this headache because I'm dealing with a trial that's looking at skin infections? You still want to report the headache because what if it's a rare event, or what if something in your intervention is causing an increase in headache frequency? If you don't collect it, you'll never know. So it's really from the time pre-existing conditions, those are not considered adverse events unless they worsen, but any new event when the participant enters into your study, those are the types of things you want to capture. Collecting these adverse events is very labor-intensive on your team. We know that, right? But it's not, but it's also something, it's a passive action, right? The participant comes back for that visit, and you or your coordinator, your research team is having a conversation with the participant, saying, how have you been? Have you gone to any emergency departments or urgent care visits? It's got to be this type of pulling it out of your participant. You can't go to your participant and say, have you had any adverse events? They're not necessarily familiar with that term. So you're really having a conversation in trying to collect information on something that's already happened in the past, or maybe it's an existing condition that we're dealing with. When you're designing your study, you have to think about what you're capturing, right? You need to specify in your protocol, and when you write your grant, you're going to have this whole data and safety monitoring plan that's one of the components of the grant submission for your trial. You need to think about it, and it's not always as simple, I'm going to collect everything, right? Some people are just like, oh, I'll just collect all adverse events. Others might come to you and say, that's a lot of burden on your coordinating team, depending on what you're dealing with, right? If you're in an acute setting with a really sick population, do you really want to collect every toe, stub, everything that's going on, especially if you're following for 6 months? You have this option to frame what you want to collect, right? So you could say all adverse events will be collected throughout participation in the trial, and that's from time from enrollment or randomization, right? You think of your start time all the way to the end of the study. Or maybe you're in a setting where really all you really want to focus on are serious adverse events. We'll get to that definition later. But you could say, okay, for my study, I want to collect all serious adverse events throughout the study period. And for those non-serious adverse events, I'm only going to collect them for the first 5 days. So think about the setting of your study, knowing that this is a process to get this information, but you're also need to make sure that you're honing in on those rare events, right? What's the unexpected that's happening? So one example, currently ongoing study is the Sleep Smart trial that's being run through Stroke Net. I work on that trial with my colleagues Devin Brown and Ron Sherman at the University of Michigan. And so we were designing Sleep Smart. Sleep Smart is looking at continuous positive airway pressure after ischemic stroke. And we have 2 outcomes. We have a prevention outcome in 6 months. So do they have another stroke within 6 months? But we also have a recovery outcome where we're looking at an MRS at 3 months. So participants go home from the hospital. You're either randomized to receive the CPAP device that you're supposed to use nightly, or you just get usual care. We'll follow you for 6 months. You can imagine there's a lot going on with this patient population in 6 months. We see them in month 3 and month 6. So we have this active conversation with the participants saying, how have you been? You've gone back to the hospital. Some people are discharged home. Some people are discharged to skilled nursing facilities. So we kind of keep track of all that as well. What we thought we would do in Sleep Smart is make it easier for the sites, because we know how burdensome it is to collect information. So we came up with this, and this is part of excerpts of the protocol. We said between the time of consent and randomization, sites must report anything that's a clinical outcome event. And we were looking at strokes or acute coronary syndrome. That's our primary outcome. And we said, and only SAEs and non-serious AEs of special interest that are definitely related or stand a reasonable possibility to be related to what devices we were using, which is the CPAP device, as well as we call it the NOx T3, and it tests for obstructive sleep apnea, which is one of the inclusion criteria. So we said if it's related to anything of your participation in this study, like a causal relationship, we want to know about that. We said all SAEs and only select non-serious AEs must be reported by the clinical site investigators from the time of randomization through the end of study, which is 6 months. And then we gave them a list of the select AEs, pneumonia, pneumothorax, car crashes, because we were worried about the CPAP device causing sleepiness. So we thought we were really good, right? We did all this before the study. We started the study, and we probably have it close to 110 sites is what we were planning, only in the U.S. And even though we trained sites on this, and we had coordinator calls throughout the trial, no one could remember this detailed information. So they were like, oh, I'm just going to record everything. It was easier for them to just not think about it until they knew the definition of an adverse event. They said, it's an adverse event, I'm just going to report it, because I can't keep it. We even had instructions on the top of the AE case report form. It said, this is really all you have to do. But, so there's a balance between trying to think you're helping the site versus just having a simple definition. So that's just a little caution or wisdom. Something when you're collecting adverse events, again, we're dealing with rare settings, right? I don't have a lot of numbers. Let's say if my adverse event is worsening of stroke, right? I'm probably not going to have too much of that. So I have to be consistent in how I define worsening of stroke, right? So when you report your adverse events, we use, some of you might be familiar with MEDRA. So MEDRA is a coding dictionary industry standard that we use for all our studies, because you can imagine from a site perspective, there's a lot of different terms out there to talk about worsening stroke. But what MEDRA does, and I'm not a but I can't be the one coding, right? So Measure helps coding so that I have consistency. So when I'm running my frequencies of worsening of stroke, it's combining all the different terms that mean worsening of stroke. So you want to have some kind of central coding when you're collecting your AD information. That Measure coding not only gives me like a lower level term, it goes to what we call a preferred term, so it's the common term for worsening of stroke, but it also will classify it by system organ class. And sometimes you want to look at all the infections, right, in one body system. So it's just a nice way to keep things grouped. And then what happens with all this information is you have your data safety monitoring board who's looking at this along with maybe an independent safety monitor, but your DSMB is looking at this cumulative occurrence rate, which is again why it's really important for consistency in terminology. So I highly recommend you using Measure. What's being shown during the trial or at your final manuscript? How do you show your data? So this is an excerpt from the SHINE trial that Will mentioned. And so at the end of the day, we wanted to show, it's very common, I'm sure you're all familiar with this, a forest plot of all the adverse events. And this forest plot is by preferred term. You can see all the terms on the y-axis. And then we're just showing you to do a relative risk or risk difference. There's a lot of information on this, but what are your eyes geared toward? That center line, and is the point estimate and that confidence interval completely away from the center line. And you can see there's one case there. There's the screen so small, I can't see what it is. But you can see that there's a difference.
Hypoglycemia.
There, hypoglycemia. There you go. And in SHINE, that made sense because SHINE was an intensive glucose monitoring trial, right? Versus usual sliding scale. So that was something that we were really interested in. So this gives your readers, as well as anyone monitoring the trial, just a nice visual because again, you're dealing with small numbers. You can see the numbers to the side of that plot.
The fascinating thing is we were worried about hypoglycemia because it could cause neurologic deterioration, and there's an opposite effect, obviously, with small numbers.
Small numbers, right?
In the neurologic deterioration, but
yeah. So it's just a good visual, but I'm going to talk more about China in a little bit. So who's watching all this, right? You're collecting this information, even if you're just doing your single center early phase study, someone's got to be watching this information during the trial. Now, typically, who's responsible, right? There's a lot of people responsible. You have that investigator patient level, right? We want to get timely reporting of what's going on with our participants. We have our clinical monitors coming to your site, looking at the EMR, making sure you reported everything. And with bigger multi-center studies like in NeuroNext or StrokeNet or Siren, we have our clinical coordinating center and our data coordinating center. We're looking at this information as it's coming in, helping code it. We're going to have an independent medical safety monitor reviewing these events. If you're doing an FDA study, right, we have expedited reporting rules. We have annual reports to the FDA. You have to tell your CIRB about these serious adverse events, sometimes in annual reports, but sometimes you're doing expedited reporting to your CIRB. So there's a lot of things going on behind the scenes that, as PI of a study, you just need to be aware of who's doing what, right? You're not doing this all by yourself, you're delegating some of these tasks. And then your DSMB, though, is really typically the only party in all of this process that's seeing it by treatment group, right? No one else is really seeing these cumulative events by treatment group, but that's their job during the course of the study, is to help monitor for safety of participants. So we talk a lot about there's so many study documents when we do a clinical trial, right? You have your study protocol, you have your report consent, you have your manual procedures, you have your statistical analysis plan, you have a monitoring plan, right, which is a combination of on-site monitoring but also centralized monitoring of the data, and then you have what we call the safety monitoring plan. And so when you submit your grant, you have to submit your data and safety monitoring plan, right? But that's for the grant submission. Once you actually move forward to do your study, you're going to even have more detailed information on those. And I recommend that the safety monitoring plan has certain things in it, right? Make sure you know your definitions, your timelines for reporting. What's an unexpected event? What's an expected event? There's a lot of things that can go in there, but it's your reference. Because these larger studies, we do ice cap went over how many years? 6. Yeah, these trials go on for a long time. Sleep Spark started in 2019 and we're just wrapping up, right? So we want to use these as your reference options for sure. So how do you get started, right? If we're talking about rare events, especially if this is the first time you're using an intervention, you don't know anything, right? But sometimes you're using a product that's already on the market for a different disease. That's a great starting point. You got to think about what phase you're in. Are you just starting out, or are you now in your phase 2, phase 3, and you have some information about your intervention? You want to think about the mechanism of action, what you expect the safety profile to be. What are some events that you expect to occur because of the intervention? And even if it's an event, what's the risk benefit, right? If it's a headache, maybe that's not as bad as like causing acute respiratory depression or something like that. So how do you know what is expected from treatment? You always go to that investigator brochure if it's something that's already marketed and has some information, right? So if you're trying to use, well, I think this has already been there, done that, but statins, right? When statins first came out, it was all in the cardiovascular area, and then people started to try it for MS, they started to try it for stroke, but there was so much information from the cardiovascular studies that people could go to that investigator brochure and see all the risks in adults and pediatric populations. So the investigator brochure is really helpful to know what's expected when people are exposed to these medications, right? We did a study in pediatric acute liver failure, and we wanted to use Actam. We know from the investigator brochure that Actam causes systematic infection, and it even told us at about 13% exposed. So that was something we needed to watch for in that trial. You could look at other studies that have published on the drug or device that you're using to gather that information. And you want to be mindful of what's anticipated because of the disease, right? And what's expected because of the drug, right? If you're dealing with a sick population like our pediatric acute liver failure, we know unfortunately, a lot of those kids are going to either get transplanted or die. So death due to steroids or immunotherapy, we don't expect that in that population. But death due to pediatric liver in general is about 12 to 20%. We also expected a rash due to immunotherapy. So these are things that you're going to start to pull out and kind of put things together. You don't want to do this when you start your study and when you're enrolling patients, because you don't want to react. Right? You want to really think through your plan so that you have less reaction when things pop up. Right? We don't like surprises. The next thing you have to think about is, okay, this is what I know about the drug and the patient population that I'm studying. What's that? It's almost like when you're coming up with your sample size and you're thinking if you're really clinically relevant difference. Now think about it with safety, and you have to think about, okay, this is what's anticipated. How much does it have to increase with what I'm exposing the participant to for me to start to worry about it, right? Because we don't want to have safety events, but we have to think about the anticipated rate and what's going to start to be medically concerning. Sometimes there's really not a good guidance on this. There have been papers, there's lots of literature out there about safety monitoring. Some people recommend, okay, if you're looking at a relative risk, because again, we're dealing with rare, right? So we're going to have rare events, we're going to have larger confidence intervals. But someone says, okay, well, if you have a relative risk for 3 or more, your ears better perk up, and you might look a little deeper. Sometimes that's even too high, depending on what the adverse event is and the risk, right? If it's very life-threatening, maybe you don't want to wait till the relative risk is high. This is a conversation you want to have before the study starts. Shine, going back to Sean, when I worked with Karen, again, it was this intensive glucose monitoring. Our primary efficacy outcome was 90-day MRS. We did have a primary safety outcome because it was a bedside laptop of intensive glucose monitoring. We wanted to avoid severe hypoglycemia, right? And that was defined. So we actually, Karen and the team, Steele Bruno, they were neurologists, and they were really struggling with what would be clinically alarming for the severe hypoglycemia rate. So we actually brought in an endocrinologist to help guide us in that. And they were like, okay, severe hypoglycemia during treatment, they said that if it got more than 4% in the treatment arm, because in the usual care arm it's sliding scale, so they didn't expect any severe hypoglycemia. But if it got higher than 4% in the treatment arm, they were like, we better be alerted during the study. So that was something we predefined. They also worried about death, and they said death within 90 days should really only be 14% of this population. So those are two things that we were going to be closely monitoring, in addition to capturing all adverse events. So before the study started, we just ran some numbers to say, okay, what would it look like if we're slowly enrolling into the study? And we had this discussion with our DSMB, so we just kind of simulated some simple scenarios. So if I'm 50 people into the study, or 100 people, 50 in each arm, how many events would I have to see before I hit that 4% threshold, right? So I would have to, so if I'm only 50 into it, right, total of subjects, that first row, total subjects with event control arm would be 0. I have to see 7 severe hypoglycemic events before the alarm got triggered that something was wrong. And we went on, all the way up to 700. How many would I have to see, even if I saw a few? But just having this exercise done before the study really helped everyone, the DSMB members, the monitoring team, everyone had a good sense of what they should be looking for, right? So I think it's really helpful to think through this. You're gonna have DSMB reports during the study that your statistical team is gonna help with. You might have specific alerts, like that 4%, it was gonna get, we were gonna alert people, or if a certain number of events happen. These are things you can build into it, right? Your DSMB might discuss with you before the trial starts what they wanna see. So that's fine, that's an exercise you have before the study starts. You have your medical safety monitor reviewing things in real time, but just on a single case. It's not like they're necessarily looking at it cumulatively. But these are all the things you want to spell out in your safety plan. So in the slides, I kind of give you just an example of things that you can put in your safety plan, a table of contents. Just like taking notes, writing this down into a safety plan before the studies start really makes you think through things, right? It makes you think about what you want to collect. Should we be limiting what we're collecting and the burden on the sites? So one example, back to my pediatric acute liver failure, there's abnormal labs. This happens in a lot of scenarios. How do you determine when an abnormal lab is something that needs to be reported? That's the guideline you want to give to your sites. A lot of times we leave it to the site to say, what do you think is a clinically significant abnormality? Then you should report it. We had to think about any case of acute EDD or CMV disease in our pediatric population. We also had to think about reactivations. So those are things we added to our safety plan to give sites guidance on what they needed to report. Definitions are really important. You want to know the guidelines about what's an unexpected adverse event. Again, if it's unexpected adverse event, if it's not listed in the investigator brochure or is not consistent with what is known with that intervention, then it's unexpected. If you're doing a trial under the purview of the FDA, you have to think about expedited reporting procedures. So you and your team really want to understand those regs. The FDA has great, good guidances on that. Think about what's expected, right? Is it in the investigator brochure and those anticipated that I mentioned? Definitions are really important. This is a definition of what makes an adverse event serious, right? If the outcome's death, if it was life-threatening, if it prolonged a hospitalization or caused a hospitalization, it's considered a serious adverse event. Any important medical event that may not result in death or be life-threatening, but it may jeopardize the participant, it may require medical or surgical intervention. Those are all SAEs, right? And again, you can go to the regs for these definitions. We also have to report severity and causality, right? Treatment relatedness in these studies. So severity, we highly recommend in our trials to use the NCI Common Terminology Criteria, the CTCAE, which is publicly available. I think they're just released version 6, but it's a really good tool to use again for consistency, and it's used to rate the severity of the adverse event, right? So you've probably seen grade 1 through 5, or mild, moderate, life-threatening, severe, fatal. Those are the grades of the event, right? So here's just an example. You could look up any event. I just took a snapshot of like what, if you're reporting fever, and the NCI-CTCA will tell you, okay, well, if you have only 39 degrees Celsius, it's a grade 1. So it's a really good way for your sites to remain consistent about how they're grading their severity of the SAEs, because that's going to the DSMB as well. And then, of course, you want to capture relatedness. If relatedness is a causal relationship, it's a causal relationship to your study intervention, right? So it goes all the way from unrelated to definitely related. That's a really important piece as well. Review those steps with your internal team just as much as you train your sites. You want to also train your internal team so you know who's doing what. Who's responsible for monitoring what's coming in? What is the medical safety monitor responsible for, right? Usually we have the medical safety monitor deem the event as unexpected rather than making the site do that, because it really should just be whatever's in the investigator brochure. So just thinking about the players in this whole process when you begin your study. You may have AEs of special interest, right? Just like Sleep Smart did. For Sleep Smart, again, the safety events that my investigators are really honing in on, and they gave me what the expected rates would be. So like, we want to know about pneumonia cases in Sleep Smart, but we also want to know about pneumonia cases parsed out by, did it happen within 7 days of stroke onset, or was it after 7 days of stroke onset during the follow-up period? And they grabbed from the literature what they expected this to be. This is super helpful for your DSMB as well, right? Your DSMB, you expect them to be experts in the clinical area you're studying, but they still need guidance, right? They still need to understand where you're coming from as an investigator and what you believe they should be monitoring. They're going to give you their input as well, but giving them this guidance is super helpful. Because what if during Sleep Smart, we all of a sudden find car crashes are 10%, when it's only expected 1%, right? That's going to be something that we're really going to be diving into, and then we'll be reporting at the end of the day. Safety is really complex though, because of this trying to find a signal of harm. It's not just a simple chi-square test, and you're not just looking at a p-value to see if it's less than 0.05, right? You're really looking for patterns. You're looking for maybe subgroups that are experiencing, are there some baseline characteristics that are making people more susceptible? So we're looking at these body systems, right? Sometimes, as I mentioned, we might look at the organ class versus just the preferred term. We might capture information on concomitant medications. Maybe there's something else interacting with your treatment. So there's a lot of information we'll try to put together. And it's important to look at safety by who received the treatment rather than your strict intention to treat. Because we know in the intention to treat, we analyze like we randomize. That's not necessarily the same concept for safety. We want to know who's been exposed. What if you had someone cross over, right? So we definitely have that in almost all of our trials. We want to know who's actually exposed to the intervention, and are they the ones who are experiencing the events. We do a lot of graphical figures, right, to try to tell the story of safety. So as I mentioned, there's forest plots, volcano plots. A lot of times we are looking at risk difference and relative risk between two treatment arms with confidence intervals. Think about your pre-specified thresholds. I gave you a list of references that are really good at discussions on this topic and can give some good insight in it. And then we should start looking familiar to you as you embark on clinical trials, seeing what's the event rate, what's the relative risk. Here's an example of a forest plot. I don't know if anyone's ever seen that. This is really nice because you can, it's like a scatter plot, right? And your x-axis can be relative risk, it can be a risk difference, but what you're looking for are those outliers, because those are telling you there's a big difference between your treatment arms. And it's just a nice visual to start to pattern together. One thing I wanted to mention was the difference between safety and tolerability. Tolerability may be related to safety, but it's slightly different, right? There's a lot of reasons people might not be taking their medications. The should stop taking the drug due to minor side effects, then you may have more of a tolerability issue than a safety issue, right? So thinking about what else could be impacting that tolerability, right? So especially early for the important for those early phase studies. So in summary, know what is expected with your treatment. Do the research on that. See what you can find out. If you're the first in human, then you just should know your disease population, right? And know what's anticipated because of the disease, not necessarily the intervention. Try to pre-specify what's really important because you are collecting a lot of information on safety. And you're going to have a bunch of frequencies of one, right? Because you're trying to collect everything together. But if those frequencies of one are all happening in a certain organ class, maybe there is a signal of harm there, something you're going to have to delineate. And thinking about that risk benefit, right? And that's where the severity and the serious, all that information you're collecting on your adverse events becomes really important. Definitely remember reporting timelines. You want this information from your sites. You don't want to, if you have a 12-month follow-up, you don't want to wait till month 12 to ask your participants, and what happened over the past 12 months? Because you could ask them, you all know this better than me, but you could ask a patient 2 weeks from now, and you just saw them in the emergency department, and they don't remember going to urgent care at the emergency department. So you really want to try to be timely about this. Know your guidelines, what's required from IRB, what you need to report to the FDA, and this is everything you put in your safety monitoring plan. And then I just provided a couple additional references for you. Thank you.
Great talk, thank you. Can you help distinguish between an outcome that is serious, like a recurrent stroke, sleep smart, versus a serious adverse event? When
When the outcome is, when my
yes, when
efficacy
the outcome
sure.
is yes.
Yes, so that's a good question because like Sleep Smart, for example, we're looking for prevention of strokes. But I know in my population there are people having strokes that's being reported as an adverse event. So the study is designed for that. We know there's an expected rate, but during the course of the study, my study team does not know the stroke event rate, right? So that's kept hidden from them only because it's also the primary outcome. And then my DSMB gets to see everything about it, so they can comment on that.
But they don't fill out SAE forms for strokes.
I will note that
So-
we're over time now, so we'll limit just to a couple questions.
I just want, can you make a comment maybe to the, I mean, this is specific to the biostat trainees, but one of the roles, as you alluded to in your last answer, is something we're not necessarily trained for in grad school, but you almost have to have a poker face as a statistician when you're seeing this stuff, and the rest of the team is not doing it.
Yes, so for the statisticians in the room, we all have learned to have a really good poker face, right? Because we are communicating with our colleagues during the study that you're the unblinded statistician. In industry they might have a bigger firewall, but in the academic setting we don't necessarily have that luxury. So there's not a lot of people on our study team. So you do have to be, and I think it's a learned behavior, would you say, Chris, that you really have to learn your facial expressions so that you're not, if you're having, because you as the athletic statistician may be having a very in-depth conversation with your DSMB about a safety issue that's come up. You're not the one to tell your team about that, right? That information has to come through DSMB channels. I can't alert my team, right? I'm just giving the information to my external monitoring group. So those are things that they have to learn.
One more question.
Okay, thanks, Valerie. So I was just wondering, because I think a lot of people in this room might be working on smaller single center projects. So thinking about some of the topics that you presented, do you have any specific advice that differs maybe for smaller single center projects? I'm thinking in terms of the net you want to cast in terms of what's a collectible or reportable adverse event, whether that differs if you've got 100 sites and you're worried about subjectivity and maybe sort of different levels of the
part about trying to narrow in on what you should collect. If this is your first trial and you're not really sure, then just do the standard. I will collect all adverse events because this is going to be your learning phase too of how you handle all this. If you go into it saying, I only want to collect X, Y, and Z because I really think this is all that matters, remember, we don't know what we don't know. So cast that wider net, and then once you get into it and you understand the nuances of safety monitoring, maybe then you can get a little more savvy in your future studies. Advice.
Thank you. So